that as well. Welcome everyone. We're just waiting a few more minutes for some more people to join. Numbers are continuing to go up. Okay, so hi everyone tonight. Welcome to the second official Word Day webinar for 2023. Very pleased that this is the actual 5th year of Word Day. We started in 2019. So the theme for tonight's webinar, we've got a really exciting international panel. The theme is tackling inequity in healthcare for children and young people with rheumatic diseases. My name's Eve Smith. I'm a paediatric rheumatologist from Liverpool in the UK, and one of the original Word Day organising committee members. I'll hand you over to hear from my co-host for tonight, so Yona.
Hi everyone, my name is Yona from Israel. I'm a parent of a son with the JIA. I've been involved in working with prayers and with Word Day, etc. since the beginning. In fact, I think it was even I that over just a small meeting decided on Word Day, and very excited to be here. Just one technical thing, people that want to ask questions, is a question and answer, and you can write your questions there and we will see them and answer them. Thanks.
Thanks, Yona. Sippy?
Hi, I'm Sippy Eggert, and I'm a patient advocate, work among the people who have got the children that are sick, and we try to help take information and pass it from place to place to help people improve the situation.
Thanks. And Catherine?
Hello everybody, my name is Catherine McCormack. I'm from South Africa. I have a daughter who was diagnosed with juvenile idiopathic arthritis back in 2010. She's 14 now. And I'm also from an organization called Arthritis Kids South Africa. And we're a patient advocacy and family support organization. And I'm absolutely thrilled to be here.
Thanks, Catherine. And I'll just go around the screen and the rest of our panelists can also introduce themselves. So, Sirirat.
Hi, everyone. My name is Sirirat Saruwanit. I'm a pediatric rheumatologist working at Sirat Hospital, Mahidol University, Bangkok, Thailand. I graduated from BC Children's Hospital, Vancouver, Canada, and I have been working as a pediatric rheumatologist for about 12 years now. I'm glad to join this webinar today.
Thank you. Deborah?
Yes, hello everybody. My name is Deborah Marshall. I'm based here in Canada in a place called Calgary, in the University of Calgary. I'm a professor here of health economics and health services research. I'm very excited to be here, and one of the areas of particular interest for me is really around the socioeconomic burden of arthritic conditions in pediatric populations. So really happy to be part of this today. Thank you.
Thanks, Deborah. Kate?
Hi, everyone. My name is Kate Webb. I am a pediatric rheumatologist at the Red Cross Children's Hospital and the University of Cape Town, and I'm also a pediatric rheumatology researcher. Thank you for having me on today.
Thanks, Kate. Ayo?
Yeah. Hello, everyone. I'm so happy to be here. I'm Ayo Faleye, a pediatric rheumatologist at the Lagos State University Teaching Hospital, Ikeja, Lagos, Nigeria. I'm happy to be with you this evening. Thank you very much.
Thanks, Ayo. Yulia?
Good evening, everyone. My name is Yulia Bozhganda. I'm a pediatric rheumatologist by origin from Ukraine. I am PhD in pediatric rheumatology with experience for more than 10 years, but currently relocated and working in Italy to collect and definitely to bring the best practice back in Ukraine. Absolutely happy to be with all of you today.
Thanks, Yulia. Wahiba?
Hello, everybody. I'm Wahiba Slamang. I am a pediatric rheumatologist living and working in Cape Town, South Africa. I'm delighted to be here and be discussing this very important topic with you all this evening.
Thanks, Wahiba. Ruth?
I'm Ruth Colajuri. I'm from Sydney, Australia, and together with my husband and partner in crime, I started the Juvenile Arthritis Foundation Australia nearly 4 years ago, because we have a granddaughter who's now 11 who got JIA when she was 6, and there seemed to be a gap in the policy and advocacy and political advocacy in particular areas. So we started JAFA, and we've been doing quite a lot of things to try and make some changes to help kids with arthritis since then. And it's nice to be here with you. Thank you.
Thanks, Ruth. So I'm sure everyone will agree we have a really exceptional panel, very diverse, and I'm very excited to hear all the discussions that are to come. So just to kick things off, I'd like to invite Kate and Catherine to talk to us a bit about inequity in South Africa and some of the things that they've done to address that.
Thank you, Eve. It turns out South Africa is an excellent place in which to address this topic. Many of you may know that in 2022, the World Bank assessed a whopping 164 countries and found South Africa to be the most unequal among them. Now, there are only 195 countries in the whole world, so to be the worst among 164 is a dubious honor indeed. And what this means from a practical perspective when considering inequity in terms of treating and caring for children with rheumatic diseases, it means that we have every degree of inequity and inequality imaginable. On the one hand, we have children who have access to everything they need. They are diagnosed early and they are referred to appropriate specialists and therapists to whom they have reasonable and affordable access. They have absolutely no barriers to the treatment and care that they need. And no obstacles at all in terms of treating and caring for their rheumatic disease. On the other hand, we have children who, by the time they are found, have joints that are destroyed to the point of needing replacement. And those are the lucky ones, the ones who are filtered through a broken, under-resourced, overstressed health system, and who somehow ended up in the right place at the right time and got to see someone who was able to diagnose them and potentially treat them. And in between, as I said, we have every degree of inequity imaginable. So if we can challenge inequity in treatments and care of rheumatic diseases in South Africa, I'm fairly certain we can achieve it everywhere in the world, certainly in another 163 countries. The thing is, as many of us know, having access to all the treatments and care that you need doesn't take away from the extreme difficulty and challenges of raising a child with a rheumatic disease. For those of us that have access to the treatments and care that our children need, we know that this doesn't make it an any less arduous and at times impossibly difficult journey. I consider access to treatments and care for my daughter's condition the fundamentals, the basics. I find it unimaginable to consider how I would have raised her without access to those things. And I'm in awe of families that do it. And of course, inequity in treatments and care of rheumatic diseases intersects with inequity in other aspects of our lives. Social, educational, economic. In South Africa, if it exists, we have examples of it, and it is massive, it is systemic, it is widespread, and it is often seemingly insurmountable. The structural inequity that pervades every aspect of our lives makes tackling inequity in rheumatic diseases especially challenging. It's almost pointless to ensure that a child has access to a doctor if her caregivers either can't or simply won't bring her to the clinic to see that doctor. It is equally almost pointless to make sure that a child has access to the treatment that she needs if those caregivers either can't or won't administer the treatment. And it does sometimes seem insurmountable. What we like to do at Arthritis Kids and what we focus on are the challenges directly in front of us and those that we can do something about. So our transport fund, for example, which has been an integral part of what we do for families from the very beginning, many, many years before I got involved, provides a very practical support system for families who literally can't afford to transport their children to and from a clinic appointment, which allows them to see the appropriate doctor, or to and from a pharmacy to get the medication. We have a patient in Cape Town, in fact, I work with Wahiba in supporting this patient, and this is one of the things we do. We literally enable her caregivers to transport her from her home to her clinic appointments and back home. And we make sure that her methotrexate injection is administered on a weekly basis. And in order to do that, we have to pay a nurse to literally go to her home, inject her, and come back. It's not going to challenge inequity in South Africa, but for this child, if nothing else, access to the methotrexate will at least potentially take away some of the pain that she lives with, which allows her to tackle some of the other challenges in her life. I don't have any answers to tackling inequality, but what I do know is that we can't solve this 195 times. So I'm absolutely thrilled to be connected with organizations and like-minded individuals, all of us here sitting on a Saturday night, volunteering our time, because we feel very strongly and passionately about making a difference. And it is through these collections of individuals that we will start to innovate. In South Africa, we only have 11 pediatric rheumatologists on this call, which speaks to you about the passion and commitment we have to tackling inequality and inequity in treating rheumatic diseases in our country. We should have closer to 50. We're never going to have 50 pediatric rheumatologists in South Africa. But I had a fabulous conversation with Yona earlier this year when I was very lucky to host him in my hometown. And we had an incredible conversation about looking at outreach programs from Israel, where they have an abundance of pediatric rheumatologists. And right there is an incredible opportunity to start to do things differently. And that's what we're going to have to do. We're going to have to innovate if we're going to have any impact on these massive structural and systemic issues. I look forward to learning from the panel members tonight. I look forward to hearing from examples from your countries, areas where you've succeeded and you've had innovative, novel approaches to challenges. And I look forward to solving these things at a global level so that we only have to do it 3 or 4 times and not 195. Kate, I'd love to hear your thoughts.
Thank you so much, Catherine, and thank you for the opportunity to speak tonight. I think it's a really daunting topic to speak on, and when I was looking at this and thinking about what I was going to say, I know that we all feel daunted by discussing inequity in access to care that our children face. But I think that there's multiple levels of inequity. I've had the privilege of working at the NHS in London, in clinical work as well as research. I've worked in the private medical sector in South Africa, and now I work in the state sector, where we have a national health insurance, a health system that provides care to the poorest children in society. Sometimes not the greatest care, but at least it's free at the point of care, which is not true for the majority of countries north of our borders, where any access to care is far out of the reach of the majority of people. So, as Catherine says, we live in a country with a lot of inequity, but we really have this Gini coefficient because we do have a lot of rich people, as well as the tons of poor people that many other African countries have, with less inequality because they don't have the representation of this class of patient that is at a much higher access to care that we can compare it to. So if we compare our inequality to the rest of Africa, I think we're doing pretty well relatively, and we have a responsibility almost to reach out to those places. I think defining inequity in pediatric rheumatic disease is difficult, and as far as I understand it, there's four main factors to this. There's number one, the factor where there's inequity in an access to a diagnosis. We know that far, far more children with rheumatic disease exist than are diagnosed every year. And this is different across many countries. And as I said, we are relatively lucky to have a network of pediatric rheumatologists and pediatricians in our country where you at least have a chance of a diagnosis. But in most countries north of our border, that's not the truth. There's ways we can fix this, and we're working to fix this, and it's incredible the gains that have been made. We have an African Pediatric Fellowship Program where we've trained the first pediatric rheumatologist in Ghana, Nigeria. Ayo's on the call. We're training someone from Malawi currently, and on Monday, my pediatric rheumatology fellow from Ethiopia arrives. So those are huge gains to make, and it does happen exponentially quickly. I was only the second trained rheumatologist in South Africa who had been trained locally, and now there's 11 of us. So it does seem to happen quickly. I think the second topic that we should discuss tonight is not just your access to the diagnosis, but once you're diagnosed, your inequity in your access to treatment across countries, across sectors, and in general. Equally, access to supportive services. Our children don't routinely have access to a multidisciplinary team. When I worked at Great Ormond Street, I was privileged to see a psychologist, a physiotherapist, an occupational therapist, and those are very lacking in the majority of places. And then just a plug from my own personal point of view is my mentor, Lucy Wedderburn, used to say that we're not providing a comprehensive service to these children unless in these relatively rare and poorly understood diseases with poor treatments, we're not including every single child or offering every single child the inclusion in data, in collecting data and in research, because we're not going to make gains in improving therapy, in knowing which therapies are the best, in knowing which children need which therapies, unless we really improve the data that we understand about these diseases. All of the treatments that we have for rheumatic diseases have been developed in the UK or the US or in Europe. None of them have been developed with the needs of children in Asia or in Africa in mind, where they're equal populations of children with these diseases. So we repurpose these guidelines based on data that doesn't represent our patients. We don't use any scientific data from our patients to develop treatments, to think of novel treatments, and we don't understand the causes of many of these diseases. And unless we include more people with diverse genetic backgrounds, diverse exposures to different immune challenges, we won't understand this. So I really feel like increasing or decreasing the inequity in access to research that our patients have will not only be good for our patients, but actually improve treatment for people all over the world with rheumatic diseases. So yeah, I'd like to just open up with that and the different inequities that we found. But I also want to talk about positive strategies and hope we speak about those tonight. one of them being the APFP program that I've mentioned, and other strategies around the world that I know are taking place, looking at really lobbying funders to fund research in these diseases outside of the traditional places. And I think it'd be great to hear about some of the work that Dr. Slamang is doing with advocating for access to care for these patients throughout the world. So thank you.
Okay, thank you very much. I think we'll come back to Africa and Asia, but I would also like to hear maybe from Ruth. When we were in the prayers conference, she gave an incredible lecture about that actually in Australia, which is a relatively well-to-do country, there are lots of problems of access to care, access to medicine, etc. And what she did in order to advocate both the government, etc., in order to receive this equality. So even in countries that are relatively wealthy, this problem exists. So Ruth, if you can give some idea of what you did and what the problems are.
Thank you, Yana, and that's you took the words out of my mouth, because that is exactly what I was going to say. I have worked in various countries in Africa as a health professional in the past, and of course the situation in Australia is not as inequitable as we just heard described, but people I think would be very surprised to hear just how inequitable it is for children with arthritis. So nobody really knows what happened, but juvenile arthritis got left behind. So when our granddaughter was diagnosed, my husband and I, who's also worked as an endocrinologist, also worked in health all his life, we sort of looked at each other and said, this is like diabetes services were for kids 40 years ago. And we had expected to see arthritis centres, such as there are diabetes centres with multidisciplinary care and, one-stop shops where families could take their child and see the paediatric rheumatologist and the eye doctor and physiotherapist and whatever else they needed, the dermatologist who had psoriatic arthritis, in one place at the same time, and have a truly team care. And that is absolutely not the case. So we, that's the reason that we started the Juvenile Arthritis Foundation, was to advocate and lobby and activate, I should say, as well, about that. So, I think the aspects of inequality are interesting insofar as it's quite a complex thing. I mean, we have social inequalities, lack of access to care because of social inequality, geographic inequality. It's a very big country. It's about the same, not quite the same size as Canada, but almost, in a very similar federated structure politically. But access is very uneven for people living in country areas. They sometimes have to make, or some people tell me they travel for a couple of days because they can't necessarily get all the appointments on the one day. So they travel from wherever they live to one of the capital cities, and you'd be surprised to learn that not all our capital cities have a paediatric rheumatologist. So there's none in Tasmania, there's none in our Australian Capital Territory, where the seat of our parliament, and there's none in the Northern Territory, which you might understand because it's a bit remote, but the others are just incomprehensible why we don't have the services there. And of course the issue of educational inequalities, where kids get left behind and sometimes discriminated against either passively or actively, and are therefore disadvantaged in terms of learning and subsequent work opportunities and so forth. So we have 13 full-time equivalent paediatric rheumatologists for a population of almost 26 million people. I think there are about 20 of them altogether. And sometimes when we advocate to governments and we put in proposals to our state and territory governments to increase the paediatric rheumatology workforce, and they say, oh yes, but there's no one to fill these positions. But there are people to fill the positions. Our paediatric rheumatologists tell us that they get, when one of them told me recently, he gets 4 or 5 inquiries from people, a paediatric rheumatologist overseas, who would like to come and live and work in Australia. We don't have the positions. So in New South Wales alone, we have 2 paediatric rheumatologists, which amounts to 1 full-time equivalent in the public sector. There is, and that's for about 3,000 children. There's There's another pediatric rheumatologist who only works in the private sector because he can't get a job in the public sector. So there are people here all the time. I don't know whether any of you, I think she trained in Vancouver. We have a lovely young pediatric rheumatologist who's just come back from her training, her overseas training, who's looking for a job and can't find one. So I think the trick is, and I'm not quite sure yet how we do it, but we're working to try and meet up the two and sort of, find positions for these people and find care for the children who can't access them. And of course, the worst thing is the lack of access to services. One of our pediatric rheumatologists did a study, was published in 2017, that showed that that Australia was about, I think it was something like 225% behind other equally developed countries in access to, optimal care, to optimal standards of care, and it was about 60-something percent behind sort of, the lowest standard, well, not the lowest standards of care, but, very standard standards of care. And that almost half of our children did not have access to multidisciplinary care. So it is a massive problem for us. Jaffa was fortunate to be able to, well, we had some help from inside among politicians, have a parliamentary inquiry last year, and that parliamentary inquiry recommended increasing our workforce by tripling our workforce, our paediatric rheumatology workforce, and that includes nurses and physios as well as doctors. And we're still working on getting the government to respond and fund some of those priorities. And our approach to that has been, we're undertaking a cost of illness study. There's very little baseline data in Australia about what happens to these kids or how many children there are with arthritis or where they are. So we're about to launch a registry for juvenile arthritis. That's been a lot of work, and my husband's looked after that. And that's actually going to be launched next week as part of our Juvenile Arthritis Week celebrations. So part of our response is bundled up in holding Juvenile Arthritis Week, which started, well, today is Sunday for us, so it started yesterday on Word Day to celebrate Word Day. And we adopted the theme of inequality in line with ENCA. And so part of those celebrations are the launching the registry. We're also in the middle of an active phase of a national cost of illness study, looking at hospital costs and so forth, the out-of-pocket expenses, and the impact on quality of life. And so that's basically our response to it. We have a football team who's going to wear, or they're not going to wear them, they're going to have some kids wearing juvenile arthritis t-shirts, and a lot of, a very strong social media campaign throughout. So we're hoping that will help. I mean, the more people, of course, who hear about juvenile arthritis, the stronger we become. And wish us luck, and wish you all luck with what you're doing as well. And thank you for having me on the program tonight. Tonight. It's this morning for me. Getting confused.
Thank you, Ruth. We find it very inspiring listening to everything you've managed to do. And I hope you also managed to follow it in your footsteps. I'd like to remind all the participants that you too can ask questions. You can just click on the Q&A little square at the bottom of your screen and type in questions that you would like to send to the to our panelists. Wahiba, I would like to, we've heard about your important work at the WHO Global Medicine List. Could you please explain to us and tell us about how you hope to counter inequality this way?
Thank you. Yes. So this is actually quite an extensive project, and it's been going for a number of years. And the idea has really been to try and update or revise the current WHO EML so that it reflects standard of care for JIA. They do have some of the medicines that we are using on it, but the task force had a look at it and reviewed it and found that there were quite a few deficits in that. So if you look at the project as a whole, it was really the Global Pediatric Musculoskeletal Task Force that started it, and they represent our community. I mean, we are the people who actually use these medicines, and we need to have it sort of authorized on a more global level, because everybody is doing their thing in their country and trying and fighting and doing what is necessary to get access to these medicines for their patients. But the idea with this project was to actually then go at a more global level, look at it worldwide, see what people think, is needed. Because we all know that the WHO essential medicine list informs the national formularies for many countries, particularly the ones in lower and middle income areas. So that's where it started. They have started with a very close relationship with the WHO Secretariat. And the idea was that they were being advised at that point as to how to do those applications, what was needed in those applications. And at the end of it, the first submission then went through in 2020, I think. And sadly, it was rejected. The WHO Secretariat said, look, we have some concerns about this. We do have medicines on our essential medicines list. Why can't you use those? We're also concerned about infection risks. We're also concerned because you're asking for high cost medicines. So went back to the drawing board, and this is where I came into the project. So in phase 2, somewhere in the middle of everything. And we discussed the whole thing, and it was decided that clearly there's a lack of understanding, I think, of what JIA entails, what the subtypes are, and how we treat each subtype maybe differently, and therefore we need different medications to treat those subtypes. So the kids who have systemic JIA, for example, would benefit not from a tumor necrosis factor inhibitor, but rather from IL-6 like tocilizumab or the anakinra, depending on which country you're in. And interestingly enough, also the list did not have intraarticular steroid injections on it. So those were the 3 medicines that were applied for. So triamcinolone hexacetonide, anakinra, and tocilizumab. And then as a group, it was decided that we would formulate a report, update the information that the WHO has, and say that the modern management then of JIA would be X. And because of that, we would then ask again the rheumatology community, you've done a survey, you've agreed that these are the medicines that we need to apply for. Do you still agree that these are the medicines we should apply for? And what are the barriers to using these medicines in your country? And interestingly enough, that survey was also published. And in that survey, it was clear that it was the cost of medicines that's an issue, yes, but also the availability of those medicines, rather than the worries and the fears about anxiety around infections and other concerns. So what we've done is we've compiled this report. We've drawn a huge evidence-based answers to all the questions that the WHO raised. We've got this extra survey, and that's now been submitted again. And we're hoping, fingers crossed, that when they have their next meeting, that it will meet with a more favorable response. But also on a sort of more global level, in tackling inequality, we're looking at using all this information that we've gathered as a resource for future applications. If you're wanting to do the same thing at national level, then you don't have to start from scratch. You don't have to reinvent the wheel. The information is there. It will probably just need to be updated annually. And then it can be used, to promote the use of these medicines in your country. So that's just in a nutshell what we've been doing. It's taken a long time. I think it's been going since 2019. But I think persistence, perseverance, you jump through the hoops because you have to. And fingers crossed, we will get where we need to be. Yeah.
Thanks a lot, Wahiba. That's such a valuable piece of work, and so much work, that it's taken such a long time, and having to go back and perseverance, as you say. Yeah. Deborah, I'd like to ask you a question. Can you tell us a bit about the project that you're working on, and the impact that you hope to have for children with rheumatic diseases through your project.
Yeah, no, thank you for asking, and absolutely delighted to speak to this. And I'm really excited to hear. I've been enjoying this whole session, learning about the activities that other people are doing and the important work, and it also very much aligns with some of my messages. So as a health economist, I was really privileged to be able to work and be successful with a whole team from 6 different countries on a program called Producing an Arthritis Value Framework with economic evidence, and we affectionately call it PAVE as acronyms go, which is about paving the way for rare childhood diseases. And it really stems from many of the things that our presenters were talking about today around data. And really being able to leverage data and evidence in a very concrete way to make, the pleas and the arguments and the changes that I think all of us are very interested in seeing. And this whole program is built around the idea that there's this hidden burden, and I don't really like the word burden, but this is what's used in the economic literature as cost of illness. Ruth was referring to that earlier, because most in our work, when we've looked at the literature and in the reportings, the reality is we don't have a lot of information that's neatly packaged in a consistent way that's measuring things that are really important around the impact and the implications of these diseases. So especially, as all of you are very well aware, in inflammatory diseases in children, if you aren't able to have access, if you aren't able to recognize and diagnose, if you aren't able to treat quickly, there are absolutely irreversible consequences. And yes, there's certainly data and reports that address the direct costs. We're able to capture things like hospitalizations and visits to rheumatologists, visits to GPs, medicines. There's also an enormous hidden burden, and that's where PAVE was sort of focused on. And we have this collaborative partnership at 6 different countries with Israel, Germany, Spain, Switzerland, Belgium, and Canada, to look at this both clinical and the socioeconomic burden of disease. And a really key piece of this is the health inequities. What we do know is that there's dramatic impact based on the differences, and some of them were mentioned here, the type of JIA, the recognition of the JIA, the access to care, access to treatments, access to different other social services as well. And we see these manifested in long-term outcomes. These are children, after all. And it goes not only in terms of the costs from direct care, but all of the costs that families and their communities have to absorb that often get missed. And I don't think we really understand the socioeconomic impact from a broad economic viewpoint that's really important to governments and to our society broadly, because it has an enormous impact on being able to go to school, to get education, for opportunities for work. So it's the whole quality of life, work productivity, and then economic, like our finance people in Canada and other countries should be very worried in some ways, because children don't necessarily get to live their fullest, brightest, most active lives if we don't pay attention to this. So we're trying to bring that lens to this hidden burdens with our families and all our collaborative partners. Yona and Tipsy are our critical partners in Israel, looking at ways that we can have mentorship programs for patients and families. But the output of this will be create what we call a value and impact framework, looking at how do we measure this impact. I'm a health economist, so we like to be able to measure things. And if we can measure it, I would argue we can manage it. That's one of the classic business school kinds of things. We work directly, with patients, the families, and the communities, trying to capture this in a quantitative way and really create the evidence package that we need to advocate, essentially, for how important and critical impacts these diseases have. So our goal is to have standardized measures to create, shared safe spaces, because we need to do it securely, where we can share these data, because it's rare diseases. We need to work together. I think one of the main messages, we need to work together to capture this in a consistent way, to make the convincing arguments to governments and payers about how critical the impact of these diseases are and the long-term consequences. And we see the inequities by socioeconomic factors. In Canada, Indigenous people have much higher, like multiple times mortality from these diseases than other people in the population. People in distant areas, and we have a lot of them in Canada, have much higher rates of disease, and in some cases take up to 13 years to get diagnosed in a study that was done in Canada, even though the mean is 4 months overall. 13 years to get diagnosed. Well, all of you know what happens in 13 years in a child. They're no longer a child. And now they have this irreversible damage. So this is where our program is focused on in PAVE. So thank you for letting me share that with you.
Thank you, Deborah. I mean, I know it's my dream that you can go to a government and say, look, you're not giving this medication that looks expensive, but actually it's a lot more expensive not to give it. So I'm hoping one day we could get to that. Julia, if you can give us also some background about Ukraine, about what's happening. Ukraine is a war-torn country at the moment, and what we can do to help. I'll just tell a very, very short story about Ukraine, because each individual is important. Right in the beginning of the war, I was contacted by someone who's actually from Russia, telling me that there's a Ukrainian girl that's got JA that's in Italy, and she doesn't know what to do. She's suffering and she doesn't know what to do. And she said, like, maybe I know anyone. So I do know lots of doctors in Italy. So she was near Rome. So I called up a doctor now in Rome, and she was taken care of. So, with these international things are also very important, the people, and across the world, that we can help each other. But we'd like to know more also specifically about Ukraine and what we can do.
Thank you, Yona, for your question, and a very brief update. Probably a year ago, before the war started, I would never expect that this international connection will work so much. Because according to the official data, up to 30% of our patients with orphan diseases, and we know that GIA, they're as well orphan diseases, they're now abroad and they're receiving medical support abroad. So probably for the first 6 months of war, I did all my efforts that I could afford for these patients to try to join them to the physicians, pediatric rheumatologists that I knew from the centers that we cooperated for many years, for a long time in different projects, just to help them to receive this as medical assistance. Because I know that in majority of the European countries, it's quite complicated to be assessed in a short time to the pediatric rheumatologist. So that is probably one of the first points that I would like to underline and stress, that this international cooperation is probably one of the first points that we need to develop. Because it seems for us that, oh my God, what does it mean, this international cooperation? It's something very general. It works. It works with every single patient that we have. And really, it was very important to underline that every patient is important for us, because we are talking not about the expenses that we are losing for their treatment. We are talking about their life. But if we are talking about the inequality in Ukraine and about the levels of the inequality of Ukraine, By general, we can present quite good picture in the brain. We have trained pediatric cardio rheumatologists from the older system because they are trained as cardiologists and rheumatologists together, probably in a very old-fashioned manner of the education, but still they're available. They're available in a public hospitals. But here we are talking, if this patient who is planning to attend this physician is able to achieve the really high quality medical care according to the standards that we are discussing. And here is underlying the same purpose that was discussed from the South Africa, that we have some access, of course, but we are not sure that we are providing this patient with those standards that we used to discuss in our congresses, in our discussion. Because if you know some material, if you know how to help this patient, but you just don't have abilities, you don't have these drugs registered in your country, you're not able to provide this patient with the treatment because simply parents, they're not able to buy the therapy by themselves, and the government does not provide in this therapy by itself. So that is the hugest gap of the inequality. We are not probably assessed to all the medication. And the last probably that I'd like to underline, and it's very important, that is the education. Education for doctors, we understand in our society what does it mean, but it's very important to educate our patient. First of all, to give them ability to feel that they're not alone with this disease. We have to support this. If you're not able to provide them with psychological support, with occupational therapy, with physiotherapy, you as physician, as pediatric rheumatologist, have to be psychologist by yourself. You have to support this family. You have to support this child. You have to explain that you're not alone. We will go all this long way together. You will be supported. You can trust me. But you have to rebuild the type of mind of these people. They have to start to trust physicians once again. So you have probably to step down a little bit to get lower to their level, to explain every single moment that we used to discuss in our society, but at the language that patient and their parents will understand. So the inequality is probably not mainly at the access to the drugs and medication, but as well at the probably lower level of the education, but we definitely need to work with this. Thank you.
Thanks, Julia. I want to continue on this note really and see how we can, how the practitioners really manage to bridge these gaps on a very practical level. I think to myself, in our country, we have gaps that are due to distance or due to language differences. I'm sure that you also can think of very specific gaps which exist in your practice. And I was wondering perhaps if Ayo and Sirirat could give us examples on how they combat these difficulties. Do you want to start, Ayo?
Okay, thank you so much for this opportunity. Thank you for your question. It's been tough in my country because we do not have health insurance. Just few people have health insurance. And I must tell you that the pediatric rheumatology kicked off officially last year, February. And in 1 year, we have 85 to 90 patients. Out of the 85 to 90 patients, I'm sad to tell you that not up to 10 can afford care. Now, let me tell you the mistake I made before I went for training in South Africa, because I started my training with the adult rheumatology unit of the hospital before I traveled to Cape Town to continue with the pediatric rheumatologist. I was with the adult rheumatologist. We write investigations that are necessary for the patient, and what happens next is that they don't come for the next clinic appointment. We were losing them. We were losing patients because we insisted on doing the right things. But in the past 1 year that I arrived, I don't really mount pressure. That's one of the ways in which I've been approaching this problem. For example, let's imagine I have a patient with a mouth ulcer. I have malar rash.
Well, sorry, I think we've got a problem, I think, with Ayo's connection. Siddharth, do you want to talk to that question now, and then Ayo can come back in? Or Ayo?
Okay.
Oh.
Yeah. So most times now,
okay.
I don't mount pressure. Okay. So once I can identify the signs and they come into the consulting room with symptoms, I don't mount pressure on parents to do serology. What I do, I look at the signs, I look at the symptoms, and I make my diagnosis. Then I tell them, I inform them about the investigations to do, and I ask them if they can afford it. Most of the time, they can only afford baseline investigations like full blood count, ESR, urinalysis, but to do our serology, because we do not have machine for serology in my country. So most times when we ask them to do serology, we take the blood samples to some South African labs. They take the blood samples and we don't have results for a good 10 working days. That is about 14 days because you can't count weekends. So I don't mount pressure. What I look at is how to save the child's life. So I'm trying to bridge the gap by not sending them away. I hold on to them, treat them based on the signs and symptoms that I can see. Most of them, I cannot even do methylprednisolone pulsing for them. I do oral prednisolone. I give the high dose and I try to wean off. I'm just trying to be practical. There is a serious problem here. So apart from that, some of them are able to afford the serology. I tell them about it. They pay for it. When they are back with the result, I treat them. But that now depends on the stage of the disease at which they have presented. Assuming the child has presented, let's say an unconscious child, I can't start to talk about all form of investigations. I try to look at what is available and I make use of it so that they do not default from clinic or or discharge against medical advice. Now, some other times, what have I done? We do get some NGOs that may be interested in these children, and they are able to fund some of these investigations or get medications for them. Then sometimes we have a philanthropist. We have philanthropists too. They come in, they can be of help to these children. But majorly, I'm telling you the truth, that when it comes to standard care, I only inform them, but I may be unable to do it. Now, how has it affected me as a person? I'm always sad because when I know what to do, but I cannot really do it for my patients. Imagine my patient in need of ICU care, and I've informed the parents about ICU care, which is going to cost them about $1,000, and they cannot afford it. I am leaving the hospital, the patient is unconscious, patient is deteriorating. You know, I will feel sad when going home. And then because of these factors, I have lost 2 patients this year. Patients that are unable to afford dialysis, patients that are unable to get ICU care and are presented so late at the end stage of their disease. And these are the problems. And I think it is better than before because now at least there is somebody that can diagnose them. So now the problem is, how can we investigate and treat them? That is where the problem is now. At least we know about these diseases now. In the past 8-9 years, we don't even know about lupus, we don't know about JIA. So I feel that there is a progress. We know them now, but the problem we have is with investigations and then with treatment. Thank you very much.
Thank you, Ayo. That it's heartbreaking, but your resourcefulness is amazing that you're able to help at least some of your patients. Siddharth, could you describe how you deal with these difficulties?
Thank you. I would like to share my experience in Thailand. So when I finished my training in Canada and I came back to Bangkok, Thailand about 12 years ago, at that point we had only 4 pediatric rheumatologists working in Thailand. So it is not enough. So pediatric rheumatologist is quite new subspecialist in our country. So they don't know what are we doing. They don't know that the children can get arthritis, something like that. So we set up the fellowship training program to try to build up the pediatric rheumatologists. For right now, we had 15 graduated pediatric rheumatologists from both centers in Sirat Hospital and Rheumatic Hospital. Both belongs to Mahidol University. And now we have about 23 pediatric rheumatologists. However, 70% of us working in Bangkok, so it's not enough. And so I think the main barrier to taking care of children with rheumatic disease in Thailand is the limited or insufficiency of pediatric rheumatologists. And also right now we try to teach general pediatricians and general practitioners to know more about children with rheumatic disease, so they can screen and refer those patients to us earlier, because we know that if we treat them appropriately at the beginning, the outcome is better, something like that. And the second main barriers in our country, so we don't have, we have limited access to biologic agents. For example, we don't have anakinra, we don't have abatacept, and no belimumab. And about steroid injections, we have only triamcinolone acetonide. We don't have TH, triamcinolone hexaacetonide. So I'm so happy, and thanks to the WHO to do like a essential medical list to get the list of essentials medicine for all over the country. I do the same way. So I know that the steroid is not good. So because we don't have the access to biologic agents in systemic JA patients, I prescribe steroid. So the patients have a side effect from steroids. So, but we don't have better option at that point. But the things is getting better right now. That's all for me. Thank you.
Thanks a lot, Surat. It's great to hear about how, how things have changed since you've gone off to and got your training in Canada and brought it back, and how things are starting to improve. But obviously there are still challenges that you have to deal with day to day. So we're getting close to the top of the hour. So I'd just like to go round the panel and just ask everyone to briefly comment on something that they've learned from the webinar, from the other panelists that could help in their own country. So I'll just start with, I'll start at the bottom of my screen. So Ruth, can I start with you?
Yeah, well, yeah, that's a tough question, because I think I've learned quite a lot actually, and it's just very interesting to hear what things are like in different countries. And I now feel terribly embarrassed after listening to the last few speakers about saying how badly off Australia is, because it's obviously much better off than many countries. And I think just learning about what people are doing, and Deborah, I'm very interested in what Deborah was saying from Canada about her cost of illness study work, but about the services on the ground and what's available and what's not available is, I find, very interesting. And I just, I think what I would also like to hear about, and it's something that, we've done quite well with Jaffa in getting some things happening, but I don't think patient education is anything like it should be. So the pediatric rheumatology teams that we have, work very hard at it, but there's no systematic education. There's no literature about patient education, not only patient education, behavioural, psychosocial, aspects of care and living with this awful disease. And I just hope and wish we can learn from other organisations around the world about how we can improve that, because I know what it should be like because of diabetes. I vaguely know what it's like in cancer, and we just don't have anything like that. And I just wish we did. And I think most of you are way ahead of us in that regard. And I'd really like to learn more from you about that aspect of care.
Maybe that's a good theme for next year's webinars.
Great.
Wahiba, can I Wahiba, can I bring you in now to tell us about something that you've learned from the webinar?
Yeah, I think, from the work that I've been doing, I'm a clinician first, and the sort of research aspects and the work with the WHO has all stemmed from the fact that I think as clinicians with these little patients, we are drawn into advocating for them, so we have to inevitably become part of the whole of changing things. So for me, I think it was really interesting to hear from Deborah about the sort of cost of illness studies, and that will be useful because now, having worked with policymakers, they want the numbers. The research is there, it's all proven what we need to know, but they actually want the numbers, what is the bottom line? And I think that's very useful for me, and I've learned that, especially now from Deborah. Thank you very much for that.
Thanks, Wahiba. Yulia?
From those that I got from this evening, it was really incredible that in different parts of the world, we are actually fighting approximately the same problems. They're manifested in different phases, but they're quite the same. We're talking about the inappropriate diagnosis, not in time diagnosis, incorrect treatment, not assessed patient to the treatment, absence of the psychological support. So I guess until we are so enthusiastic here, we have to keep together and to improve, continue to improve this work. Because if not us, no one will do it. So we have to continue this work, even if it will be critically complicated, but we have to do this because we have our patients standing after us and they're awaiting for the support, and we have to provide them with this support. Thank you.
If you're on mute.
Oh, sorry. Ayo, do you want to come in?
I had a little disconnection the other time, so I came in just a few seconds ago. So I wasn't there when you asked the last question.
Sorry, we were just asking for people to, we'll come back to you, but the question is for people to mention one thing that they've learned that could help in their country from the other speakers. But I'll come back to you because you didn't know the question. Kate, do you want to come in?
Okay, thank you.
Yeah, thanks, Eve. I think there's many practical points that I've learned, but more importantly, listening to Yulia speak and Ayo speak and Surat and people who are facing such challenges. But there's hope and there's resilience and there's progress. And when you spoke about the connection of people that helped your patients, Yulia, I think that that's what this is, Eve, for example, us getting this platform to share and speak to the challenges that we face, speak to the creative ways that you do things. For example, we all know what the guidelines are, but we all have to be creative, be resilient. And, the people that exist on this call weren't here 10 years ago. These patients didn't have access to any of these clinicians, I don't think. So that's already 100% improvement. And I think that for me, I have to cling on to that hope that things are getting better and there are connections being built and that there's goodwill to improve this inequity. And just having this webinar really helps with that.
Thanks a lot, Kate. I think it's definitely shown that we're all stronger together and we need to just keep working at that, don't we? Catherine, do you want to come in with something that you've learned?
Eve, I'm not sure I can add very much. I agree with what everybody says. In particular, if I combine the work that Wahiba's been doing with the World Health Organization, with some of the work that Deborah is describing, just those two things alone, if we could each implement those, the impact of those projects in our own countries, it would be incredible. And there's a solution in that. People who are best equipped to tackle one aspect of this enormous challenge that we all face, who runs off and does what they have to do and then brings it back to the rest of the world. And that we're not trying to do everything together, but we are bringing all of our individual resources together. And I think that's a very exciting way to challenge some of the inequity that we face.
Thanks, Catherine. Deborah?
Yeah, I have to say I've learned something from every speaker, and thank you for sharing. I think what I would underscore is the idea of let's not do it 156 times. Let's do it 2 or 3 and learn from each other. The power is in the people. And honestly, the patients, as I'm getting along in my career, I think I see myself very much as a helper, to try to bring the data, try to bring the evidence, to try to make the arguments we need to. And I have to say, I was really excited, Wahiba. We had talked about the essential medicines in our JIA work previously, and I know it was a long road. I'm really excited. I didn't know it had been revised and resubmitted, so I think that will be very helpful for everybody. You know, getting governments to recognize arthritis as a disease even was a major roadblock for us about 5 or 6 years in Canada. And being able to get medicines on an essential medicines list will also be really critical. But there's so many day-to-day things as well that I think I've learned from each one of you in different ways, in your own different contexts. And, you know, that's the other thing. Yes, the general issues might be the same, but I think each of us has to apply them in our own context and figure out how to make it work. So congratulations and thank you to all of you for doing that.
Thanks a lot, Deborah. Sirarat? Oh, I think she's frozen. Sirarat? Or Ayo, do you want to come in, Ayo?
Yes, Eve, thank you so much for the question. One thing I have learned is that it can get better, because Kate said that she's the second trained pediatric rheumatologist in South Africa. I am the first. I know that one day we are going to have the second, and I believe we are going to push hard, and we are going to be noticeable more than now, and hoping that our patients too, they will get health insurance. And surely I know that it's going to get better. That's what I have learned. I know that one day will be more than, it will be more than me. We're going to have other colleagues in this field, and our patients will receive optimal care. Thank you very much.
Thanks a lot, Ayo. Sirarat, are you able to comment now? I think you froze when we asked you before.
Yes, first of all, I would like to thank that you invited me to this webinar. I feel that I'm not alone, and I learned a lot from all of you. I feel more support, and I feel that everything is going better and better every day. Thank you.
Thanks a lot, Sirarat. So I think we should come to a close now. I'll maybe just end on, there's a comment in the Q&A from Rebecca Beasley, who I know has been unwell today. And I think it's maybe a nice, oh, it's just disappeared. It was a really nice way to end it. I think essentially Rebecca was saying, we need to keep this momentum going. You're right, no one else, no one else is doing it if not us. So it's all about keeping up the momentum and keeping going together, and that we're all stronger together. So thank you very much for everyone who's spoken today, and happy Word Day, and everyone get on the social media and tweet, share, all of that, and lovely to see you all. Thank you very much for joining and for all your input. Bye.
Bye. Thank you, everyone.
Bye-bye.
Thank you.